Module 7, Nutrition. So the concepts for this module include the whole study of nutrition, which is the study of food, how it affects the body and influences health. Good nutrition is essential to wellness, and poor nutrition contributes to disease, which is why it's so important that you as the RN know this whole concept and see the bigger picture so that you can help your patients get adequate nutrition. Metabolism. This is a process by which the body converts food into energy. So nutrition, metabolism, they go hand in hand. Reliable sources of nutrition information. So who is telling us what to eat and how much and what's good for us and what's not good for us? There's lots of different agencies, government agencies, health agencies, and they come up with these standards and food guides. So standards are a reference for a nutrient intake that are thought to meet the nutritional needs of most healthy population groups. We don't know everything. We try to do the best we can. Research and studies have been done, and this is what they come out with. We have to trust information, right? So on the next slide, this is our reliable, trusted information. Food guides. Food guides are practical tools that you can use to educate patients and families. So here we have the Food and Nutrition Board, or FNB, and they promote the consumption of micronutrients, macronutrients, and other substances such as fiber. And they have developed this Dietary Reference Intake, or DRI, that are used to plan and assess diets for healthy individuals. Emphasize the word healthy. When we have somebody who is sick or has complex things going on, this doesn't apply to that. So we're looking at healthy people. And there is a link on this slide if you're curious, where it goes into great detail. So here we have the U.S. Department of Agriculture, or USDA, and the U.S. Department of Health and Human Services, and they have their own set of dietary guidelines that you see here. It goes into great detail if you want to check that out. Also, your textbook, box 24-1, has lots of other details on this. But basically, the USDA dietary guidelines are intended to be a primary source of health information for like nutrition educators, policymakers, and healthcare providers. And all of this is based on evidence, based on studies and research, and it provides information about a nutritious diet, maintaining healthy weight, achieving adequate exercise, and ensuring food safety also. And these dietary guidelines are updated every 5 years. So if you see this Choose My Plate here, this plate takes the place of our food pyramid, which was something that was taught in schools all across the nation for a very long time. So we no longer have the food pyramid, we have the food plate. And if you look at the food plate, it's very simple. It's meant to be really easy, so you can just kind of see your proportion size. So it doesn't give any calorie recommendation. It doesn't give the specific foods. It's just very broad. So fruits, vegetables, grains, and protein and dairy. So that's what you should include in your diet, and you can kind of follow the proportion that it gives an example for. Food labels. So the FDA requires that this label, this nutrition food label, is on all packaged foods sold in the US. So every single food product should have a nutrition facts label. And this is something you want to bring to the attention of your patients, because if you're not told to look at it, if you're not familiar with how these things are set up, then you're probably not going to look at it, and it's not going to mean anything to you. So patients who, for example, are diabetic and need to kind of watch their carbohydrate intake should know how to read a food label. Or maybe they are on a heart-healthy diet, a cardiac diet, and they need low fat, low sodium, low cholesterol, then they need to learn how to read a nutrition label. Maybe somebody who is overweight and they're on a lifestyle plan, change of plan, dietary intake plan, then they should be looking at calories and serving size, all of those things. So you as the RN should be familiar with this also, so you can educate your patients. Okay, now into nutrition. So under nutrition are nutrients. So nutrients are the building blocks for cells and tissues. They supply energy and they help to maintain, manufacture, and repair cells. So what you should think about with this is if we want to have energy, if we want to make and repair our cells that we are made up of, we need nutrients, we need to eat. Nutrients are found in foods, so this has to be consumed. And the way that they're used, they're going to be changed into something that the body can use through metabolism. So here are our energy nutrients. This includes macronutrients and micronutrients. So macronutrients supply the body with energy, also known as kilocalories. And this includes carbohydrates, fats, and proteins. Then we have our micronutrients, and these micronutrients help manufacture, repair, and maintain cells. And these include vitamins, minerals, and we throw in water in there also. So macronutrients, the reason why they have macro at the beginning of their name is because we need those in higher amounts, in higher quantities than micronutrients. Micronutrients, we just need a little bit per day versus macro. Then we have these two terms of two types of metabolic reactions, anabolism and catabolism. So these are continually happening and they are adjusted depending on the needs of the body. Okay, so they're constantly happening, anabolism and catabolism. So what are they? So anabolism is the formation of larger molecules from smaller ones. So we are synthesizing, we are creating a larger molecule. For example, if a protein is needed for tissue repair, then amino acids are combined to form proteins. So amino acids make up proteins. Okay, so if we are building them up, this is anabolism, and this process requires energy. Then we have catabolism. This is the breakdown of larger molecules into smaller components, meaning it's just the opposite. So you have the protein, so catabolism is going to break down the protein into its amino acids. This process releases energy. Okay, our first macronutrient we're going to talk about is carbohydrates. You can also call this CHO. In the hospital, sometimes they'll say that the patient's on a CHO diet. CHO, that is referring to carbon, hydrogen, and oxygen. So carbohydrates are our primary energy source. We also know it as sugar or glucose. And undigested carbs are fiber, which is good for us. Okay, functions of carbs. So it supplies energy for muscle and organ function. So if we don't have enough carbs, our body does store some glucose in the form of glycogen in the liver that can be used. However, when glycogen stores are low and patient or the person has some physical activity going on, it's going to cause the body to catabolize proteins and lipids. So it's going to start breaking down proteins and breaking down fats. Carbohydrates also play a role in nutrition and metabolism, so it enhances insulin secretion, it increases satiety, which is the feeling of fullness and satisfaction after eating, and it actually improves the absorption of sodium and excretion of calcium. So really important. Carbohydrates are not bad, it's just humans, we need a balance. Okay, next macronutrient is protein. So protein is, its primary function is tissue building. Then a nitrogen balance is also at play here. So this has to do with the balance between anabolism and catabolism when it comes to breaking down protein and synthesizing protein. So you are said to have a positive nitrogen balance when you have more synthesizing of protein than you do breaking down, and then vice versa. You're in a negative nitrogen balance when you are breaking down protein faster than you are synthesizing it. So that would be bad. We don't want that to happen. Functions of protein. So tissue building, we keep saying that, tissue building, because it is so important. That is essential for growth, maintenance, and repair of body cells and tissues. So we need protein in our body. Metabolism. So proteins are essential for building body tissue. In our immune system, our white blood cells and antibodies are actually proteins. So again, essential. Fluid balance. Proteins attract water, such as albumin inside of our vessels. So it's really important. It plays a huge role in our fluid balance in our bodies. Acid-base balance. So blood proteins function as buffers, and it actually helps to regulate our acid-base balance. And then we have a secondary energy source. So we can use protein as energy. The body can break it down to provide energy when we don't have any lipids or carbohydrates. So it's kind of like a last resort. It's not good when our body starts to break down protein for energy. Next macronutrient is lipids, aka fat, and it's a key component of all lipoproteins. It's a backup energy source after carbohydrates, and it provides organ insulation and protection. So there is a purpose for it in our bodies. So lipids are made up of carbon, hydrogen, and oxygen, the same elements as carbs. So fats are solid at room temperature, oils are liquid at room temperature. So that's something to remember when you're educating your patients. Lipids, okay, so there are several different types of fats. We have glycerides, which is a true fat. This includes our triglycerides. Sterols, lipids, they don't have any fatty acids in them. This includes cholesterol. So cholesterol is a substance that we need in our cell membranes. Okay, it's very important in our cell membranes. So if you have a very low cholesterol level, your cells become very fragile, and that is not a good thing. Phospholipids, you've heard of the good and bad cholesterol. So we call this low density lipoproteins is LDL, and then we have our high density lipoproteins, HDLs. So the LDLs we want to keep low because they're not the good type of cholesterol. The high density lipoproteins or HDLs, we do want a high level because that is the good cholesterol. So more functions on lipids. So they supply essential nutrients. Food fats supply the essential fatty acids and aid in the absorption of fat-soluble vitamins. So we need fat in our diet, and we'll talk about fat-soluble vitamins coming up. Energy source, so the body burns fat for energy when engaging in sustained light activity. And when those glycogen stores in the liver are exhausted, then that's when the lipids kick in. Flavor and satiety, so lipids or fats, they do promote satiety. It makes you feel full. Fats are digested more slowly than carbohydrates, so it takes longer to empty the stomach, so you feel fuller longer. Moving on to our micronutrients. So this includes vitamins, waters, and minerals, and these are required in smaller amounts than macronutrients. Now, these don't provide energy for the body, but they are important in regulating body processes. And when you are lacking in certain types of micronutrients, that can alter the body's ability to use certain macronutrients. So these go hand in hand. Okay, vitamins. So what are vitamins? Vitamins are organic compounds required in small amounts for normal metabolism. And primarily they are involved in enzyme reactions. So they're divided into two categories. We have the fat soluble, which is ADEK, vitamins A, D, E, and K. These are stored in the body and they're not readily excreted, and it's for that reason that we don't want to give a patient too much of these type of vitamin supplements, because if your body doesn't need them, they're just going to get stored and they can become toxic. The exception to this would be vitamin D, because many people, it's kind of common to be vitamin D deficient because we get 90% of our vitamin D through our skin from the sun. So for people who don't go outside a lot, or maybe they work night shift, may have some vitamin D deficiencies, so you may need to take a supplement of that fat soluble vitamin. Then we have our water soluble vitamin, vitamin C and B complex. So these have a rare likelihood of becoming toxic in the body because we excrete them, we don't store them. And also for that reason, that means we have to keep ingesting them. And just to be clear, the body cannot make vitamins. It has to come from our diet. Okay, moving on to minerals. So minerals are inorganic elements found in nature. They occur naturally in some foods, food additives, and some supplements. So minerals interact with other minerals. They can interact with vitamins and other substances in the bodies to accomplish absorption, metabolism, and to perform their own functions. So for example, iron is you can take iron just by itself, but if you take iron with vitamin C, the absorption is much better. So that's how they kind of help each other. As one example. So if the body is deficient in a mineral, it will absorb more from the diet. And if it has had enough, then it will absorb less and it will excrete it in the feces. So pretty good system. So here are our major minerals. It includes our electrolytes, calcium, sodium, potassium, phosphorus, magnesium, chloride. There are a couple missing there. Minerals assist in fluid regulation, nerve impulse transmission, and energy production. They are essential to the health of bones and the health of blood, and it helps to get rid of the body of the byproducts of metabolism. So calcium, for example, will decrease the likelihood of osteoporosis when you have the recommended daily intake. However, it is difficult sometimes to get that in just diet alone. So in the US, calcium deficiency is actually one of the most common mineral deficiencies, but it's really important to prevent osteoporosis. So when a patient comes in, if you are working like in the primary care setting and the patient's coming in for their annual, physical and blood draw, calcium is something when you look at, especially as the patient gets older, because it's common to be deficient in that mineral. Then we have iron. So iron deficiency causes anemia, and it is actually the most common nutritional problem worldwide, and that's why we check for these things, like I said, like at physicals, just to see, because they're very commonly low. Magnesium increases the risk of hypertension and coronary artery disease in women. Sodium, when consumed in high amounts, more than about 2,500 milligrams a day, can increase the risk for blood pressure, heart attacks, and stroke. So these are all very important. Okay, this slide is just showing you some examples of our trace minerals. For trace minerals, we need smaller amounts than the major minerals. And water. So water makes up a very large percent of our body weight, more than half. It helps to transport things in our blood. It's a solvent for chemical processes. It's a form for tissues. If we didn't have water, our tissues would just kind of flop around and our organs wouldn't stay in shape. And water actually helps to maintain body temperature. For example, when body temperature rises and you sweat, the evaporation of that sweat helps cool the body. And this is just a picture of the human body, so you can kind of get a look at the elemental composition. It's kind of interesting. Next is energy balance concepts. So we measure energy nutrients in calories. The amount of calories in must equal calories burned. So to maintain a stable weight, the number of calories consumed must equal number of kcal burned. So if you take in too few calories or nutrients, you're going to be undernourished. If you take in too many calories, then it may lead to obesity, and which will put the patient at risk for lots of other chronic diseases. So below in this chart, or this little box below, we have the energy liberated from metabolism of 1 gram of energy nutrients. So for 1 gram of carbs, you get 4 kcals of energy. With 1 gram of protein, you get 4 kcals also. But for fat, for 1 gram, you get 9 kcals of energy. And then let's talk about this basal metabolic rate. So the BMR is the amount of energy required at rest. So when you're sitting down and you're not doing anything, you're just breathing, thinking, and your food is digesting, the amount of energy your body needs to do all of those processes is called the BMR. Then we have our total energy needs, and this is the amount of calories we need for our total energy needs. Okay, so how do we obtain these vitamins? Okay, so vitamin 12 is the first one. So this is only found in animal products such as eggs and milk. So if you're vegan, you need to eat foods that are fortified with B12, or you need to take B12 supplements. If you have a long-standing B12 deficiency, this can result in irreversible neurological impairment. Then we have vitamin D. So vitamin D, like I mentioned before, we get 90% of it from the sunlight exposure directly on our skin. It may be inadequately supplied by vegetarian diets. So again, they should have vitamin D fortified foods, or supplements should be included. Usually soy milk or dairy milk is the most common fortified food. However, adequate sun exposure can help compensate for the lack of the dietary intake. So if you're a vegan, then spend a little extra time in the sun and maybe you won't even have to take a supplement. Then we have iron. So iron from plant foods is not absorbed as well as that from animal sources, but, and I think I mentioned this earlier too, iron is easier to absorb when it's paired with something containing vitamin C. So eating fruits and vegetables containing vitamin C can help with meals to compensate for that, such as a glass of orange juice. Okay, then we have calcium. So calcium is especially important for the growth of vegan children and women who are pregnant or lactating. So this is because vegans, it's especially hard for them to find enough dietary calcium. So it is so extremely important for them to include fortified nuts and oat milk, and including calcium-rich vegetables into their diet. They also have cereals that are fortified, so that's an option. So that's important. Zinc. So zinc, the best source of zinc is oysters, but it is found in beef and chicken, and you can get it from some beans and some seeds, squash, watermelon seeds, chickpeas, dark chocolate, garlic. And we have our protein. So we have complete proteins and incomplete proteins. So complete proteins contain all of the essential amino acids necessary for protein synthesis. And these usually come from animal sources. Incomplete proteins do not have all of the essential amino acids. However, if you combine two incomplete proteins, then you can make a complete protein. For example, would be peanut butter on whole grain bread. Combined, that would be a complete protein. If you ate those separately, they would be incomplete. All right, so let's go back to our basal metabolic rate and factors that affect that. So body composition. So if you have lean body tissue, that has a greater metabolic activity than fat and bones. And that actually explains why women who have an average more fatty or adipose tissue than men also have a lower basal metabolic rate. Okay, growth periods. So your basal metabolic rate increases during growth spurts, like the first 5 years of life, during adolescence, pregnancy. Body temperature. So the BMR increases 7% for each 1 degree Fahrenheit rise in body temperature. So if you have a patient that has a fever in the hospital, then their BMR is going to increase, which in turn is going to they're going to need more calories, because this is going to increase their metabolism. Environmental temperature. So if it's really cold, especially if it's like below freezing, it's going to cause a slight rise in the BMR so that the body can start generating heat and maintain a normal body temperature. Disease processes, diseases and injuries involving increased cellular activity will result in a higher BMR. And examples of that would be cancer, asthma, burns. Then we have prolonged physical exertion. So not much to say about that. You're just using up all your energy. You're gonna require more energy. Your BMR is going to raise. Okay, factors that affect nutrition. So developmental stage. So at certain developmental stages, the nutritional needs and eating pattern will vary, and just depends on their physiological growth, their activity level, and other factors. So this includes lactating women. So when a woman is pregnant and are lactating, their nutrition requirements increase dramatically. So that is why those women should be on supplements and healthy diet. So there are many other factors that affect nutrition, including lifestyle changes, being a vegan or vegetarian. if you're eating for health, if you're eating to lose weight, your culture, your religious beliefs, medications that you're on can affect it, and if you have a special diet that you're following. So there are a lot of things that can affect nutrition. So when you have a patient, you want to ask them all of these questions, like, oh, tell me what you eat in a day. When we screen for nutritional problems, you want to get a diet history. You want to know what the patient is eating. You can ask them, what did you eat in the last 24 hours? You can ask them how often they eat certain foods, like how many times a week do you eat fast food? Or how many times a week do you cook a home cooked meal? A food record can be helpful. That's like a diary, write everything you ate for a whole week, and then, you can kind of look at it. And based on that activity we did in class, you can tell it's not always 100% reliable. A lot of it is subjective, but it can be helpful. And then there are several different standardized tools that can be used to do like a mini nutritional assessment, stuff like that. So now we're going into identifying nutritional imbalances, so alterations in nutrition. So how are we going to assess this? Well, we're going to do a general survey, and we're going to go into each one of these in detail later. We want to check the vital signs. We're going to look at the skin, assess for poor skin turgor, concave abdomen, change in muscle mass. All of you should be familiar with these terms. And we're going to check the labs, and we'll go into these labs in a second. Okay, alterations in nutrition, body mass index, or BMI. So this formula, this calculating BMI, it is an old practice, it is an old formula, and you can see by this picture that it's not 100%, doesn't really 100% pick the picture of the patient. So if you have a BMI of 45, like this guy here on the left, you would say, oh yeah, he looks pretty healthy, he's in good shape. But then this guy is also BMI 35, and he doesn't look as healthy. So that number is not black and white. However, they still use it, so we still teach it. All right, so here is some numbers for you. So being considered overweight according to BMI is from 20, we'll say 30, 25 to 30, and then it goes up from there. Class 1, 2, and 3, all the way up to 40 or higher. Now, if you're underweight, this means that you have an insufficient intake of protein, fat, vitamins, and minerals, and you're consuming less calories than needed according to your physical activity, your gender, height, and weight. Those things are all part of it. Some of the causes may be psychological, social, economic, or physiological. Maybe it's due to a recent hospitalization, or maybe you're not able to care for yourself, something like that. And a person can also be malnourished related to certain nutrients without necessarily being underweight. So just because they have a quote healthy weight, it does not mean that they are not malnourished, because maybe they're not getting all of those essential vitamins and minerals in their diet. So this is straight from your textbook. That's why I put the little picture of your textbook here. And it's really good. I highly recommend you skim through this. I'm not going to read every word, but again, you're going to start with a general survey. That's with you just kind of standing there looking at the patient. Does the patient look ill? Do they look, like they have energy? You want to check the temperature, your vital signs, height and weight. That's going to give you your first glimpse at, the overall patient. You're going to go and do a body system assessment. You're going to look at the skin. Skin is so important because when you are malnourished, you don't have enough protein, and we don't have enough protein for your body to kind of rebuild and repair skin. It shows up on the skin. So skin turgor, you know how to check that. It can show indicator of fluid loss or dehydration. Skin integrity, if you have wounds, you're going to have poor wound healing if you don't have enough protein, vitamin C, or zinc. So slow healing wounds, they can turn into infection, gangrene, eventual amputation. Areas of warmth or erythema could be inflammation or infection, and other lesions you find on the skin. The nails, so spoon-shaped, brittle nails can be related to deficiencies, vitamin A, iron, A and C, all kinds of things. Hair, your hair may grow really slow, it can be thin, it can break easily if protein is deficient. So this is where it's important that you are able to recognize what's normal and what's abnormal. So if you know what a normal body should look like, what the hair should look like, the nails, and you discover something abnormal, like, hey, that's not right, you need to investigate further. And if you have other things, you kind of cluster your data, then it could point to having some kind of nutrition problem. Head and neck, you can read through this. Cardiovascular system, abdomen, musculoskeletal, neurosystem. So let's look at the signs of severe malnutrition. So if you are not taking in adequate nutrients, you can see all of the different things that it's going to affect. It's going to affect the person from head to toe. All of the bodily processes are not going to happen as they should. So you're going to see reduced physical activity, weight loss, and reduced height. Okay, this is over time. So children, older adults, people with chronic illnesses like HIV, COPD are likely to experience malnutrition. Just a little bit about COPD. So this chronic obstructive pulmonary disease affects the lungs, and there's much more respiratory effort. So they're always at a state of needing a lot of calories. And sometimes just eating is difficult for these patients. It takes a lot of energy. They can't eat and breathe at the same time. So they often will experience malnutrition, just for your knowledge. Okay, so in adolescence, you can look for delay of stages of sexual maturation. So if the body doesn't have nutrients, especially when a person or a child is growing, when those nutrients are so highly essential, then you're going to see it from head to toe. So which lab values are we assessing for nutrition? So one is going to be blood glucose. If you have high levels of blood glucose, this is going to trigger the release of insulin, which is a hormone secreted by the pancreas, and that is going to help that glucose to enter back into the cells to be used by energy. If you have low levels of blood glucose, that is going to signal the release of a hormone called glucagon, which is going to tell the liver to convert that stored glycogen into glucose. For our purposes in this nutrition module, hypoglycemia is less than 50 milligrams per deciliter, and that when it hits 50, that is when the body is going to start having some changes, where it's going to potentially starve itself, and that can lead to weakness and coma. So I don't want you to get confused with that number of 50, but hypoglycemia is usually 70 and below. That's the definition we use. But for nutrition, we're talking about 50 and below, because that's when the fuel becomes limited for the body. And that's when some serious things can happen, like weakness all the way to coma. Then we have hyperglycemia. That's when we have too much blood glucose in the blood, and that could be a sign of diabetes mellitus, not necessarily, but that is something we want to think about, especially if the patient has other signs and symptoms. Some other levels that we're going to look at. So serum protein levels is really important, and I hope everybody understands why protein is so important. First on the list is albumin. So albumin is made in the liver, and it makes up about 60% of total body protein, which is pretty significant. If you have low levels of albumin, that is associated with malnutrition, malabsorption, liver disease, maybe loss of protein through wounds or like burns. Albumin is also affected by fluid status, so you can't always depend 100% on that value that you see, because there's other things that could affect the albumin level other than nutrition. So then we have prealbumin. So prealbumin fluctuates daily, and it's for that reason that it's considered to be a better marker of like acute changes rather than albumin. Then we have transferrin. This is another protein that binds with iron. So transferrin only has a half-life of 8 days or so, and it allows for faster detection of protein depletion than measuring albumin. Again, albumin can be affected by lots of things, including malnutrition. Prealbumin, transferrin is a little more accurate. It also correlates with iron, the status of iron, so it goes hand in hand with your iron studies. Then we have urea. So urea is formed in the liver, and it's an end product of protein metabolism, and then it's excreted through the kidneys in urine. So The serum blood urea nitrogen, or BUN, is an indicator of liver and kidney function. So an elevated BUN level can be seen with impaired renal function, dehydration, excessive protein breakdown, starvation. So that's why we also look at that level. Creatinine is the end product of skeletal muscle metabolism. It's also excreted through the kidneys, and it is a great indicator of kidney function. Increased levels could mean that there's impaired kidney function or loss of muscle mass. Again, we're thinking for this chapter, we're looking at the potential loss of muscle mass. Then we have lymphocytes. That's another, that's a type of white blood cells. They're the first line of defense for our body, if you remember that when we talked about our immune system. So a decrease in the total number of lymphocytes is called leukopenia, and that is associated with malnutrition, protein deficiency, alcoholism, bone marrow depression, and anemia. And lastly is hemoglobin. So hemoglobin is composed of heme, which is the iron part of it, and then globin is a protein. So we need adequate iron intake to produce the heme. And then we need the protein part because they are BFFs, they are friends. So protein is essential, and I hope when you look at your lab work, especially when you go on to Med-Surg, you can kind of get some hints to solve the mystery on whatever's going on with your patient. Okay, this is diagnostic testing. This is straight from your textbook, your Davis textbook. Just kind of read through this. You should become familiar eventually with your creatinine range, your BUN, your hemoglobin, your blood sugars. You're going to know all of these by heart soon. What is the relationship between nutrition and hydration when it comes to wound healing? It's really important. A lot of words on this slide, so you can definitely read this on your own. Low protein is at the top, so you're going to have slow healing wounds, or maybe they won't even heal at all. You're going to have leaky vessels, so you can get edema, and it's going to affect the oxygenation of cells in the skin, because when you have edema, it decreases the skin elasticity, and that can affect the diffusion of oxygen. Low cholesterol. If you have low cholesterol in your diet, remember in our cells, we need cholesterol to make our cell membranes nice and strong. So that's going to lead to, weak cell membranes. It also contributes to making us water resistant. I can't think of the word, hydrophobic. So that will lead to skin that's prone to breakdown, and that will inhibit wound healing also. If you have inadequate calorie intake, so that means we're not giving our body enough things to break down for energy, then the body is going to use proteins for energy. Remember, that's called catabolism. And that means that if we're using our protein for energy, that protein isn't going to be available when our body needs it for building and for health maintenance in our body, for our cells and tissues. If you have prolonged malnutrition, that can cause weight loss. You can lose some of that fatty tissue, that subcutaneous tissue, and you have muscle atrophy. So that padding between skin and bones decreases. And if you don't have any padding on your bones, then those bony prominences can lead to pressure injury much more quicker. If you have deficiencies in some vitamins and minerals like vitamin C, zinc, copper, you're going to have a delay in wound healing. And those are involved in the formation and maintenance of collagen, which is in our skin. So all around not good. Fluid. If you don't have adequate fluid intake, you can lead to poor skin turgor. You can end up having dehydration overall. Edema may result from overhydration, so we're looking at both not enough and too much fluid. If you have a lot of fluid and it causes edema, or if you have not enough fluid and you have really poor skin turgor, both of those things make the skin more prone to injury, especially if the patient is bedbound. Shear and friction are more likely to happen, and moisture. So it leaves the patient very, very high risk for impaired skin integrity. Moving on to special diets. So one point to remember is that you are responsible for ensuring that the patient receives the prescribed diet. You need to make sure that when Dietary comes and provides a tray, that it's what it's supposed to be. And if it's not, then you are going to make sure the patient gets the right tray. Okay, so to promote compliance with the patient, because many of our patients come in and they don't like hospital food, they don't like to be limited on what they can eat or what they can drink. So you want to explain to them why they have this diet, why they are on a clear liquid diet, why are they NPO or nothing by mouth. Usually once you educate the patient, they have a better understanding, they'll have better compliance. So here on the right hand side, you have a chart, and we're going to talk about this on the next slide, of the different types of diet and the foods that go under each diet. So we have nothing by mouth, so that might be because they're going to have a procedure, whether it's a surgery or just a regular, some other procedure. Or sometimes they just want to rest the GI tract. Maybe they have nausea and vomiting and they don't want the patient to eat anything. So they shouldn't drink anything, they shouldn't eat anything unless the doctor writes an order that specifically says what they can eat or drink, and that's what we follow. We have clear liquid, full liquid, soft or low residue. When you see the term low residue, that means low residue in the bowels, so fiber, they're referring to fiber, so that's going to be low fiber foods. Then we have high fiber, we have sodium restricted. There are lots of different types of diets just depending on the patient's situation or disease process or both. Okay, if a patient is going to be NPO, again, NPO is nothing to eat or drink, then an alternate route of nutrient intake is necessary. And we're going to go into that a little bit more later. But let's define enteral nutrition and parenteral nutrition. So enteral nutrition is referring to you're still using the GI tract. So instead of you putting it in your mouth, chewing it and swallow, you have a tube, whether it's a nasogastric tube or a gastrointestinal tube to deliver your nutrition. Parenteral nutrition is intravenous nutrients. So you have a catheter in your vein and you're getting liquid nutrients. So let's talk about our therapeutic diets. So there are a couple of reasons why a patient would be on a therapeutic diet. I mentioned a couple before. So if a patient is NPO, and that is named after the Latin nil per os, NPO, no food or fluid at all by mouth, no ice chips, no sips of water, unless the doctor specifically writes that on the order. Okay, so clear liquid, so liquids that leave little residue, so like clear fruit juices, gelatin, or broth. Full liquid is going to be clear liquids plus liquid dairy products and all juices. So you want to remember the order that this goes in. So sometimes you're going to get an order where the patient starts off with clear liquid and then the order says advanced as tolerated. So you're not going to jump from clear to mechanical soft. You're going to start with clear, then you start with full liquid, maybe something softer after that, and so on. Okay, then we have pureed. That's pretty much everything's blenderized. Mechanical soft is referring to the mechanics of chewing. So it needs to be soft and chewable. Those are going to be diced or ground foods. Clear and full liquids are included. We have soft or low residue. This is low fiber and easy to digest. Calorie restricted, that's straightforward. High fiber, straightforward. Low sodium, no added salt, or 1 to 2 grams sodium, just depends how the order is written. Low cholesterol, diabetic, renal, dysphagia, and regular. So a dysphagia diet will usually consist of pureed food and thickened liquids, which we'll talk about on the next slide. So thickened liquids is for a patient who has a hard time swallowing thin liquids. Maybe that thin liquid just goes back in the back of their mouth too quickly and it causes them to choke and gag. So if we thicken their liquid, then they hopefully won't aspirate. There's a few different types of thicknesses. We have thin, which is like water, nectar, which is like fruit nectar, and then honey, which is like honey thickness. And here's a picture of it here. So we will have this thickener that we can use. It's like a starch, and you just add little by little until you get the consistency that you want. On that package, it usually tells you how much to put in to make your desired consistency, but they're not always accurate, so you just kind of have to, trial and error. So in order for a patient to have this type of order, we need a speech therapy evaluation. They're the ones who are going to do the swallow evaluation, and they will recommend what consistency of liquid the patient should be drinking. So if a patient came from another facility and you got in report, like maybe the patient came in through the emergency room from a skilled nursing facility, and it says the patient is on honey thick liquid, temporarily you will follow those orders. However, during that hospitalization, that patient will need another speech therapy evaluation. Okay. Okay, so this is some examples of some orders you may see. NPO after midnight, NPO accept medications. That means the patient can take their meds with a sip of water. NPO accept ice chips, NPO accept sips of water, and so on. You could have a regular diet with nectar thick liquids, puree diet with thin liquids, pretty much different types of combinations. Fluid restriction, and there's that advanced diet is tolerated. Okay, so say you have a patient who was ordered a clear liquid diet. That's all the diet order said. So that's all that they can have. Say they were ordered that because they were nauseous and vomiting, and now they're tolerating it. So you can't change the diet on your own because the diet order does not say advanced as tolerated. That phrase, advanced as tolerated, gives you the power to give them different consistencies of food. But if it just says clear liquid or full liquid, then you have to get a new doctor's order. And remember, all diets require a provider order. So if it's a new patient who's been admitted and you don't see a diet order there, you can't assume it's regular, you can't assume it's puree. The doctor needs to enter an order. Now you can recommend to the doctor, like if you see the patient doesn't have any teeth and it's obvious they're not eating a regular diet, that's something you can tell the doctor, and you know, a diet's not a big deal. They'll go by your recommendation and then they'll order a speech therapy evaluation so that they can take it from there. All right, so now let's talk about managing nutritional imbalances. So that means that the patient has a problem, some kind of problem related to nutrition. So the first thing you need to do is identify the etiology. So what is causing it? What is the root cause of this imbalance? So sometimes it could be they have difficulty chewing and swallowing, so maybe they just stopped eating. Maybe they have pain in their mouth, it hurts when they eat, so they just prefer not to eat, and then they start losing weight, they become malnutrition. Maybe they have alcoholism, so that's why their vitamin and mineral deficiencies are there. Metabolic disorders, so if you have diabetes or maybe Crohn's disease, that can all affect, you know, the way your body is able to absorb nutrients. Maybe you had some type of stomach surgery, gastric surgery, so you're not able to absorb certain vitamins as well, so you become deficient that way. If a patient is overweight or obese, you know, it could be because they're overeating, maybe they have a psychological problem, maybe it's a hormone problem. And then you also want to provide patient and family teaching. So talk to them about vitamin and mineral supplements, and if applicable, you know, how to find nutritious foods if they're not able to afford it. Calorie count is something you may see in the hospital. This is when it appears the patient isn't eating well and they're just trying to gauge to see how many calories can the patient or is the patient eating per day. So in the hospital, now this is managed by a dietitian. So the dietitian will come and put like a paper on the door or on the wall in the patient's room where whoever is taking the tray from the patient can document what percentage or how much they ate of whatever is on their plate. Those are collected after 1 to 3 days. The dietitian takes them. You don't have to do any math or anything. It's not your responsibility. And then they'll make recommendations based on this. Okay, patients who are NPO or nothing by mouth. If the patient is NPO longer than about 3 days, then we need to start thinking about another way to give them some glucose, some carbohydrates. So these patients will either have like dextrose, which is a form of glucose, given to them IV temporarily until, you know, they figure out what the plan is for this patient. You want to make sure you provide good oral hygiene for patients who are NPO. If there's a doctor's order, you can provide ice chips, gum, hard candy, sips of water for rinsing their mouth. patient needs to be able to follow commands. So you don't want to give a patient that's NPO who's confused, water to swish around in their mouth because they're going to swallow it. So just keep that in mind. If a patient is NPO, you don't want to have visitors and families eating and drinking around them. So just ask them, can you eat outside the room, or, that's kind of rude. So if a patient's NPO more than 3 days, that puts them at risk for NPO. And when older adults especially have to be NPO for a procedure, then we want to try to schedule them in the morning so it decreases the length of time that they have to be NPO. If that's not possible, like if this procedure has to be scheduled late in the day, then ask the doctor if it's okay if the patient eats an early breakfast, and it's usually going to be okay. They're going to say yes. But if you don't ask, then the patient will just be NPO all day, because it's not something that the provider usually takes into consideration, usually thinks about. So you as a nurse, advocate for your patient. Next is helping clients with nausea. So when you move on to Med-Surg and you start studying the GI system, you're going to go much more in depth with nausea. So these are just some things you can do on the foundation level. So you first want to identify the cause. So is it anxiety? Are they constipated? Is it a side effect of the medication or a treatment? That will help you better address how to treat the nausea. But generally speaking, you want to give them a cool compress for the back of the neck. Make sure they're comfortable in loose clothing. Try to not have strong scents around, because that can induce nausea or vomiting. When you serve food or drinks, if they can tolerate it, you can add fresh squeezed lemon to the water. That seems to help. You can give bland or cold foods, peppermint tea, crackers, small meals, small snacks. And you want to avoid carbonated drinks like soda. I know a lot of times patients will say, oh, my stomach hurts, I kind of feel nauseous, can you give me some ginger ale or like a Sprite? We typically don't recommend that because it can cause bloating and it can put pressure in the belly, make you more nauseous. But if the patient is insisting and maybe it's helped them in the past, then you can definitely, if the patient wants it, you can try it. You want to maintain a cold environment. Calm environment, not cold. You can use distraction, guided imagery, music, whatever helps them kind of relax. If the nausea doesn't go away, then having antiemetics given or calling to get an order for that would be needed. You can arrange for a dietary consult if that nausea and vomiting doesn't go away. If a patient has compromised nutrition, then you definitely want to get a consult from a dietitian. You may want to consider dietary supplements, but they're not tolerated well and sometimes make the nausea and vomiting worse. And when you have a patient that has been having nausea and vomiting for a long time, you want to assess for dehydration and the need to see if they need some IV parenteral fluids and electrolytes. Interventions for patients with impaired swallowing. So this is aspiration precautions pretty much. So some causes of impaired swallowing could be mechanical obstruction. Maybe they have a tumor in their mouth or in their throat. Neuromuscular impairment. So maybe they have some facial paralysis. Patients who've had a stroke or cerebral palsy could have impaired swallowing. You want to provide assistive devices as appropriate to help them make sure they're sitting upright. You can give them special fork, spoon, so that they can hold the food and bring it up to their mouth. You want to avoid the use of drinking straws because that can force liquid to the back of their mouth too fast and can make them choke. You want to make sure that their head is in forward flexion and in preparation for swallowing. So like a chin tuck, if they put their chin down, it kind of helps to swallow. You want to make sure that, for example, if they have a stroke and they have weakness on one side, that they're not pocketing their food. So you kind of tell them to consciously make an effort to move their tongue, to move that food to the back of the mouth. And then you want to check their mouth afterward just to make sure that they swallowed everything. If you gave them a medication mixed in with food, you definitely want to check their mouth to make sure it went down. You're going to check their body weight to make sure that there's no changes up or down. And you want to monitor their fluid balance, so their body hydration, including in and out, skin turgor, and their mucous membranes. More on aspiration precautions. Always monitor the level of consciousness of your patient. If they're lethargic, super drowsy, You don't want to feed them or give them anything by mouth. Make sure they have a cough reflex and gag reflex and that they're actually able to swallow. So do a little test. If you've never had this patient before, new to the hospital, test to see how they do first. Make sure they're upright. You can keep suction available if you feel like you need it. Start with small amounts, cut into small pieces, and after they're done eating, you should keep the head of the bed elevated for at least 30 to 45 minutes. Okay, now we're talking about enteral nutrition. This is tube feeding. So this is used when the patient's unable to meet nutritional needs for whatever reason. There's lots of different reasons. So by definition, this is delivery of liquid nutrition into the stomach or intestinal tract via a tube. And sometimes patients have this in addition or instead of oral intake. So maybe they're able to swallow. There's nothing wrong with their swallowing. They're just not able to tolerate swallowing for whatever reason. They don't have an appetite, or they get really tired, or they're lethargic and they just can't eat. We can put in an NG tube to give them supplemental nutrition, and the patient can still eat, as much as they can during mealtime. For this, you have to have a functional GI tract because the tube is going through, it's going to the stomach. So we still need a functional GI tract. There are some risks to tube feeding. Patient can aspirate. If the patient has an NG tube in, that tube, is keeping the esophagus open, those sphincters, and the stomach contents can come back up because the door is open. It can lead to infection, pneumonia, abscesses. It can contribute to respiratory distress syndrome and can eventually cause death. So really important that you understand high risk for aspiration, people on tube feeding. Bacterial growth. So that liquid nutrition that we're giving them is food. It has sugar in it. So bacteria love sugar. So we have to be careful with that too. And then other complications. Tube feeding has side effects. So patients can get diarrhea, nausea, vomiting. They can have issues absorbing medications. They can have a change in their metabolism. And they can have other metabolic changes. Okay, so let's talk about a little bit about skills. So we're talking about enteric tubes. So the tube that you're going to use if you're going to insert an NG tube depends on what you're using it for. So we have lavage, specimen collection, decompression, and nutrition. So to lavage the stomach, you do that when there could be bleeding in there, maybe the medication overdose. That just means you're going to clean it out. You're going to put some solution in, irrigate, and you're going to take that fluid right out. Specimen collection is when you take a sample from the stomach contents to send to the lab. Decompression is when you want to prevent nausea and vomiting, gastric distension. Usually post-op they may put this in. And then of course nutrition. So how do you know what feeding tube to use? Well, an NG tube or nasal enteric tube, we want to use it less than 6 weeks. So this is going to be temporary because you can't have a tube in your nose for longer than that because it's going to cause more problems. These NG tubes can easily be dislodged. They can become clogged. They're uncomfortable. Can you imagine having this in your nose all the time? And it can also cause injury to the skin, to the nasal mucosa. So this is definitely temporary. Okay, a term to know, lumen is the size, the inside diameter of a feeding tube. We use the French scale when we're referring to the tube size. So we'll say 12 French, 14 French. Small bore NG tubes, they're really thin tubes. Those go into the stomach. Nasal enteric tube or NE goes past the stomach into the duodenum or the jejunum, which is the upper part of the small intestine. The larger bore NG tubes, usually greater than 12 French, they're kind of stiff, they're less comfortable, and they're less flexible. So we definitely don't want to use those if we don't have to. And those are usually used for suction or to do that stomach lavage. So this is what a G tube looks like. It's soft, it's flexible, it's radiopaque, which means you can see it on an X-ray, and it's placed in the intestine. When you have a G tube versus an NG tube, the G tube is going to decrease the chance of aspiration when it's placed there. Then we have our nasogastric and nasointestinal tubes. They're always risks, like I mentioned before. It can clog easily, it can become dislodged, and it can even become knotted or kinked inside the GI tract. So here's a picture of different types of tubes. We have our nasogastric, goes through the nose. There's also an orogastric, which goes through the mouth down into the esophagus. Then we have our G tube and our J tube. G tube goes into the stomach, and our jejunostomy goes into the jejunum of the small intestine. So selecting a feeding tube. So when you have the need for a long-term feeding, maybe months at a time or indefinitely for the rest of the patient's life, we want to put in a gastrostomy tube like seen here. It's surgically or laparoscopically placed through the skin, and this is exactly what it looks like. There's a bumper. That's what you see on top of the skin. There's a balloon inside, a retention disc, so you can't pull it out. Still can be pulled out, but not that easily. Okay, here we have a picture of a G tube on the left-hand side, and then on the right-hand side, there's a button gastrostomy. So if you have a patient with a chronic G tube and maybe they're ambulatory, they can walk around, they don't want a big old tube hanging down, it can be converted into this little button. So it's less obvious and very functional. So when you want to administer an enteral feeding, if it is a nasogastric tube, you want to verify the tube position after you insert it. That's going to be done by X-ray. You are going to make sure you mark how many centimeters that NG tube is at, and you want to make sure you check it throughout your shift to make sure it didn't move. When the tube has been in and people, you've been using it a couple days, you don't have to do an X-ray, but you should check the pH and aspirate the stomach contents just to make sure it's still in place. Also, after inserting, you want to open the patient's mouth, use your pen light to make sure that there's no coiling inside of the mouth. This is a picture, pretty disturbing. This is an NG tube in the brain. This patient had some type of skull fracture, and when this NG tube was inserted, it just fed right into the brain. So this can happen, and this is contraindicated, obviously, with a skull fracture. So just be mindful, always follow procedure, always do your checks to make sure that it's where it's supposed to be. Misconnections. So safety has come a long way over the last 50 years when it comes to healthcare. And before all of these safety precautions were in place, there were a lot of deaths from things that could have been prevented. So one thing you do when you come into the room of a patient and they have multiple lines connected to them, whether it's an IV line, a Foley catheter, a G tube, or suction, anything like that, you always want to follow your lines to see where they're connected. Always take your time to do that, because you can really save a patient's life potentially. So back in the day when patients had G-tube feedings, the little connector fit IV lines. They all had the same connection, so it was bound to happen. A nurse was busy or wasn't paying attention or something and connected the feeding into the IV line. So people finally got smart and decided to make sure that all of those connections do not fit each other. So when you go to the hospital, you'll see that the little feeding tube will not fit into an IV line. But that might not be the case. You may go to a hospital in a rural area that doesn't have fancy equipment, or they don't have, that certain brand, and you just need to be mindful and just do your checks. There's nothing wrong with not having that kind of equipment, but just be mindful. Check your lines and make sure you're safe. So now let's discuss the tube feeding formulas. So there's lots of different formulas on the market. There's several different brands. It really just depends on what your facility has a contract with, but they're all basically the same depending on the brand. So if you have a brand that is for diabetic, then another brand that's for diabetic, they're going to be very similar. So depending on the patient's needs and disease process is the type of formula that they're going to get. There's a basic one, there's a high protein, there's a low carb, there's a kidney one, so it just depends. They provide nutrients, fats, they provide everything in the bag that the patient will need. Just know that this is still not normal and that there's going to be side effects. The body wants to eat real food, chew it, swallow it. And although this is still using the GI tract, it's not normal. So you're going to have some labs that are going to become altered. They may get diarrhea. They may have skin issues around the G-tube. It's just not a normal process. although the patient is getting the nutrients they need, they're still at risk for lots of other things because of they're getting this enteral feedings. And then one other thing I want to mention is that if you have a patient on tube feeding, sometimes they have a water flush. That means at a certain interval throughout the day, maybe every 4 hours, every 6 hours, there's going to be a bag of water that automatically flushes. It can be 100 mLs every 6 hours. It can be 50 mLs. Sometimes if it's a kidney patient where they have issues with kidneys, maybe they're not going to have a water flush because the patient's on a fluid restriction. So that's also something you want to take into consideration. These bags of formula, or these big bottles of formula, they don't have a lot of water in them. They're very, very nutrient dense, which means these patients can potentially become dehydrated. So just because you see fluid going down into their G tube, you think, oh, they're very hydrated. No, not necessarily. So definitely keep that in mind too when you have patients on tube feedings. Feeding schedules. So the feeding schedules of patients will vary depending on what stage they are in the disease process, their independence level, their nutritional needs, their nutritional goals. But the patients you see in the hospital in the acute setting, they're most likely going to be on a continuous feed using a pump. A pump is going to control the rate. So other options would be gravity feeding, cyclic feedings, and intermittent feedings. So cyclic feedings includes nocturnal feedings or 24-hour infusion. So maybe the patient is able to eat a little bit during the day and then they're just on tube feedings overnight while they're sleeping. Or it can be 20 hours of tube feeding and then the other 4, the machine is turned off. So it really just depends. Sometimes they transition from continuous to cyclic when they're trying to transition the patient off tube feedings completely. So they just decrease the number of hours per day. Then we have intermittent feedings. So this is like periodic feedings using a bolus method. So maybe every 6 hours, the patient will get a can of tube feeding. So during that time, they're not connected to anything. The tube is clamped. And then when it's time for feeding, you go to the room. You can either do it by gravity, where you take the plunger out of a big 60 ml syringe and you pour it like this picture here in the middle. And by gravity, it will go inside on its own. Or you can pour the can into a cup or big container, aspirate it, and then push it in. So just remember that you want to think about how you normally eat and drink. So if you have a syringe that you're pushing food into, it can sometimes cause the patient to become nauseous if you're pushing it in too fast or if it's like a really cold liquid. So gravity is usually preferred. However, sometimes their G-tube, and it also varies per patient, gravity can go really, really slow, or it can go really fast. So just keep that in mind. You can always kind of assist it with pushing the plunger, but just be mindful. The patient may not be able to tolerate that. Patients who have enteral feeding, enteral nutrition, you want to monitor them. So you want to monitor the tube placement. You want to monitor the skin condition. So if they have an NG tube, you're going to be monitoring the nares. If it's a G tube, you're going to monitor the skin around the opening. You're going to monitor labs, especially their blood glucose, their kidney function BUN, and electrolytes. You want to check their feeding residual, which we'll talk about on the next slide, and their GI status. You want to make sure that their GI tract is indeed working. So you want to check those bowel sounds, and you want to know when their last bowel movement was. Gastric residual. When a patient is on continuous tube feeding, it's important for you to know whether or not the patient is tolerating the tube feeding. And the way we evaluate that is by measuring gastric residual. So you're first going to want to stop the pump, stop the tube feeding. You're going to get a 60 ml syringe and you are going to aspirate all of the contents in the stomach. If you have more than 60 mLs that will fit in the syringe, then you need to get another container so you can keep filling it up until you feel resistance and there is no more gastric residual. Then you're going to measure the contents. So depending on the amount will depend on whether or not you're going to tell the doctor. So every facility is different. There's no specific number because there's a lot of factors at play. One is how fast is that tube feeding being infused. So if you see in this picture, this tube feeding is 200. So if you found 250 gastric residual, then that's not a big deal because it's only been sitting there for about an hour in the stomach, and that's kind of normal. However, if you have a rate of like 20 mLs an hour and you have 250 gastric residual, then that means that tube feeding has been sitting in there for several hours. So that's a big difference. So you want to also remember that whatever you take out of the stomach, you need to put it back in. So if you aspirated 5 mLs, 100 mLs, 300 mLs, you need to put it back in. And that's because in our stomach we have lots of acid, which harbors a lot of electrolytes. So if you don't put that back in, you could potentially cause an electrolyte imbalance, and we don't want to give the patient another problem. Now, say you aspirated 500 gastric residual. So 500 is usually the number you'll see in textbooks that say, okay, you need to call the doctor before you put it back in. And it's completely up to the doctor. They'll say either leave it out or put it back in. They may say to hold the tube feeding for a couple hours and then check residual a couple hours later. They may want to give the patient some medication to help it kind of move along. But your responsibility is to check that gastric residual at the beginning of your shift and sometime during your shift. You can check it every time you give meds if you'd like. You can't check it too much, right? It's completely your call. But you need to check it at least twice during your shift, definitely at the beginning and then sometimes later. If a patient has a tube feeding and they are vomiting and they're nauseous, first thing you should do is hold the feeding and check the residual. Sometimes it's because the stomach is filled up and that's making them nauseous. So still talking about how we evaluate the patient's tolerance to tube feeding. So if the patient has any abdominal discomfort, nausea, vomiting, or diarrhea, that could maybe indicate that they are not tolerating it. It could be the rate is too fast. It could be that the formula itself, if it's like a renal formula or, a diabetic formula, maybe the formula itself is causing them discomfort. Maybe they're constipated, maybe they have diarrhea. So a lot of different things come into play. You want to make sure you're listening to bowel sounds and vital signs. Your textbook says check gastric residual volume every 4 hours. That's not necessarily required. You won't be tested on that. You want to monitor their intake and output. You want to make sure you're taking weights of the patient. You're going to check for skin breakdown around the insertion site of the tube. And you want to keep an eye on those bowel movements. Patients on tube feedings typically have softer bowel movements, sometimes loose bowel movements, but you want to keep an eye on that. And then you want to monitor those lab values to make sure that the nutritional status is adequate. So before you give medications through the tubes, you want to make sure that there is drug compatibility with feeding solutions and the other medications you're giving. You want to make sure you're crushing it to a fine powder so it doesn't clog the tube. And of course, you're going to identify and make sure that tube is in the right spot. We're not going to go into this part because you have a whole chapter on that, but making sure it's the 6 rights of medication administration, giving it at one time. You're not going to crush enteric coated or extended release tablets. And then after you give a medication, you want to flush the tube with at least 30 mLs of water. A little bit about inserting an NG tube. When you insert an NG tube, check the order. Always check the order. The physician won't normally add in what size NG tube they want you to use. Sometimes they will, but that's kind of rare. So it's going to be up to you. Why is the patient getting the tube? We talked about tube sizes earlier. If it's for lavage or suction, usually the tube is a little larger. But if it's for tube feeding, it can be much smaller. Sometimes you're limited by the supply you have anyway, so maybe you won't even have a choice. It's whatever you have in the supply room. Okay, you're going to go to the room, you're going to check the nares with a pen light to make sure everything's patent. You're going to gather all your supplies, your tube, your pen light, some lubricant. Make sure you have the lubricant. You never insert an NG tube without lubricant. You're going to need some type of securement tape. If the patient's alert oriented, can follow directions, a cup with water and straw, and a towel because it might get a little messy. You're going to measure the tube from the nose to the earlobe to the xiphoid process, and you're going to mark it because that's the length that you're going to insert into the nare. And here we go. You're going to insert into the nare. Always remember the shape of the anatomy. It's going to kind of churn. And if you watch my line here, once you insert it up into about where the ear measurement is, you want to start twisting that tube to help it turn and go down into the esophagus. At this point, when you start turning, you want the patient to tuck their chin down, and that's when they start swallowing that water through the straw. And the idea is while they're swallowing, their esophagus will remain open and it will guide the tube down into their stomach. Once you have your NG tube in place and it's secured, we want to attach some kind of mechanism to lock it. Because if you look here at the end of the tip, it's just open. There's no way to lock it. They do have little lock clips that you can slide on, but it's much easier. Just use a Lopez valve. This valve will allow you to insert your 60 ml syringe to give medications, to flush the tube, to hook it up for tube feeding. So get a Lopez valve and lock it. You want an anti-reflux valve if you have this type of NG tube. This is like the vent. So this will allow the air to kind of vent out, because if you don't have this, sometimes the gastric contents can kind of back up in there and then it'll leak all over. And then you want to get your x-ray to confirm placement. If you don't do anything with that tube until you've confirmed placement with an x-ray. And that concludes this module.